2, 1. Sir, we are live now. Now we can start.
Okay. So welcome to another very exciting global collaboration between ASSI and Japanese Spine Society. This is in view of the ASSICON 2024. ASSICON 2024 has collaborated with world societies to bring the best of the discussion and academic knowledge. And we know the Japanese Spine Society is one of the at the forefront when it comes to knowledge in cervical myelopathy. So today we have exclusive discussion on the theme cervical myelopathy, especially the controversies. We know there are a lot of controversy regarding the treatment and management with it. I am Dr. Ayush Sharma. I will be your moderator, and my co-moderator, Dr. Niraj Vasavada, will be joining us soon in between. And we have a very eminent faculty, both from Association of Spine Surgeons of India and from Japanese Spine Society. The topic has already been decided. We'll also have some case discussion where we like to have a very lively discussion on and get to a meaningful conclusion. So without wasting much time, let me invite the president of Bombay Spine Society, the Dr. Ketan Badani, who is representing both the Bombay Spine Society and Association of Spine Surgeons of India. Over to you, Dr. Badani, for your words of wisdom.
Thank you, Dr. Ayush. I'm Dr. Ketan Badani. I am the president of the Bombay Spine Society, which is the host society organizing the ASSICON, which is our annual conference of the Association of Spine Surgeons of India, to be held in January. So as Ayush described, our team has a very wide vision of inviting a lot of global societies to participate in the discussions and scientific knowledge sharing. But the conference being of a short duration, it is not possible to include everyone in that. And so we have expanded. So to call, we can say that this is an ASSICON even before the actual ASSICON, wherein all leading societies from the world, like the Japanese Spine Society and other societies, have collaborated, discuss specific topics. And I welcome all our spine surgeon friends and colleagues from Japan. And it's an honor to have you here and discuss with us an important topic of cervical myelopathy. I also welcome our Indian faculty who have found time to participate in this webinar. The Japanese Spine Society is very well known for their work in cervical spine, and most of the cervical spine leading research is from Japan. And we are indeed very fortunate to have very knowledgeable and acclaimed faculty for this topic on cervical myelopathy. So I really thank all of the faculties from Japan who have agreed to find time and participate in this meeting. And our ASSICON is going to be in January, and I welcome you all to join the ASSICON if it is possible for you. Meanwhile, I hand over the proceedings back to Dr. Ayush. Go ahead with the meeting. Thank you.
Thank you so much. And let's have a brief introduction from the Japanese Spine Society. And let me call upon Dr. Takahata to just introduce the society.
Okay, good evening. My name is Masahiko Takahata. On behalf of the president of JSSR, I would like to thank you for inviting us to the ASSI JSSR Joint Symposium. We look forward to sharing the latest findings on cervical myelopathy with you. Thank you.
Thank you so much. So let's start with the proceeding and to call upon the first speaker, Dr. Kshitij Chaudhary, who will be talking upon the controversies in management of cervical myelopathy. Over to you, Kshitij.
Can you see my slide?
Yeah. Go to your first slide before
okay.
We can see.
Thank you very much, Ayush. It's great to be here. And I'm going to start with controversies. I have 8 minutes and 5 controversies to cover. So let's get into it. The first controversy is what to do for patients who are incidentally diagnosed with cervical cord compression or who have mild myelopathy. Like this 85-year-old who had some back pain issues but severe cord compression on MRI. Should we be offering this patient a prophylactic decompression? What if this patient was not 85, but a 55-year-old? Would it matter then? The problem here is that of natural history, which unfortunately we don't understand very well. The prevailing understanding of the disease is that for those who have neurological decline, they continue to decline in a stepwise fashion with a variable period of quiescence. But what about for those for whom the decline has not started or who are asymptomatic? The variability in the natural history is partly related to the disease being non-binary. Means degenerative cervical myelopathy includes a host of different pathologies like spondylotic myelopathy, soft disc herniations, instability, etc., each of which arguably has its own natural history. But the treatment for cervical myelopathy is unfortunately binary, means either you have nothing to offer or you are offering surgery. With that in background, the ones in favor of surgery argue that prophylactic surgery will prevent future irreversible neurological decline if it happens, and also reduce the likelihood of acute deterioration after a minor injury. While the ones in favor of keeping a watchful eye argue that surgery itself carries a risk of neurological decline and that acute spinal cord injury is a very rare and freak event and should not be considered in the decision making. This study is often quoted as it is a 3-year RCT comparing conservative versus operative treatment for mild to moderate myelopathy. And the results at 3 years were comparable. The same authors published a 7-year data subsequently, and also at that time, the results were comparable. But you can argue that by that time, the study was quite underpowered. This systematic review found that asymptomatic patients with SACP abnormalities or those with radiculopathy were more likely to develop myelopathy and should be counseled for surgery. The risk for progression to overt myelopathy was 8% at 1 year and approximately 25% at 4 years. This clinical practice guideline by Dr. Fellings and group summarizes this controversy quite well. The patients with mild myelopathy can be offered surgery or supervised conservative care, but the strength of this recommendation is weak. Probably other factors should also be considered, like for example, soft disc herniations are more likely to recover than hard spondylotic myelopathy, or that relatively younger patients leading an active lifestyle may be considered differently than an old retired person. For patients who are non-myelopathic without any radiculopathy, the guideline recommends conservative care. But for those with radiculopathy, the patient needs to be counseled that they are at a higher risk for progression and can be offered surgery as an option. Coming to the second controversy, which approach, anterior or posterior for multilevel stenosis? And approach-related issues are covered well in the next 2 talks, so I'll keep it very brief. This study by Michael Fellings and group was a prospective multi-center study, and it compared anterior versus posterior in 264 patients, where the surgery was the surgeon's choice. Predictably, the surgeons chose anterior for younger and fewer levels and posterior approach for multi-level disease. Overall, both groups did well, and end of the day, it did not matter much, except for the complications. But you may wonder if this is a fair comparison as the 2 groups were dissimilar at baseline. So let's look at this RCT. This is the best study on this topic available so far by Zohar Goganwala and group. In this study, the patients were randomized in the anterior and posterior groups, which means that the surgeon could not choose anterior or posterior surgery. The surgeon only could decide which kind of anterior surgery he had to do or which kind of posterior surgery the patient was randomized to. And at 2 years, the outcomes were similar in terms of neurological recovery. So then it comes down to complications. The group having the highest complications was anterior, 47%. But if you look closely, most of them are due to a minor complication like dysphagia, which is an obvious approach-related temporary issue. Actually, the highest complications were seen, and the least was for laminoplasty. Now, in this study, very few centers did laminoplasty, so we don't know actually if their good results were because they were technically good at it, and whether the low complication rate would be replicated by others who are not used to doing laminoplasty so well. And we don't know that. So in the end, it comes down to surgeon's preference. We are currently doing what works best in our hands, considering that the neurological outcomes are the same, but complication rate differs. The next controversy is disc replacement for myelopathy patients. So you may wonder, motion preserving operation for myelopathy, how is that going to work? We know that dynamic factors are at least partly responsible for spinal cord dysfunction, but you can also argue that motion preservation works if the decompression is adequate. And that is why laminoplasties and laminectomies work. This study by Dan Rue found that as long as you have retrodiscal compression, it has the same outcomes. But if you have retrovertebral disease, OPLL, or congenital stenosis, where you are going to remove much more bone, the total disc replacement is not a good option for them. And other papers also have shown that total disc replacement works. The next controversy is whether one should use intraoperative neuromonitoring routinely for all myelopathy patients. Some argue that neuromonitoring either expensively documents an irreversible injury if the injury is meant to be reversible, abnormal neuromonitoring will revert to normal spontaneously. While others argue for medico-legal reasons, it is always better to use IONM. And the primary purpose of using intraoperative neuromonitoring, if you see, is to detect a problem early and to take corrective steps early. Therefore, the only potential situation where neuromonitoring might be efficacious would be a situation where signal changes could warn the surgeon of a repetitive dangerous maneuver. This is a large retrospective database study that did not find a routine use of INM useful because it did not demonstrate a reduction in neurological deficit when it was used. But we know that INM helps detect positioning problems and traction-related problems, even cord insults due to low blood pressure. Both of these events have happened to me personally. Corrective steps were taken and the patient was fine. But these events should be classified as neuromonitoring saves, where the course of the surgery was altered by the monitoring. Such events are impossible to be captured in a retrospective database study like the one I quoted previously. So in short, neuromonitoring can help, but is it mandatory to use it as a routine? Probably not. The final controversy, and probably the least controversial now, is the ability of signal change in the spinal cord to predict a neurological outcome. And in the past, when MRIs were new, the T2 signal change was considered as a sign of permanent damage to the spinal cord and an irreversible injury. But as MRIs have improved, we have seen surgical outcomes of these patients, and we have understood that not all signals changes mean a bad prognosis. Studies have found that a sharp demarcated signal change as well as a multi-segmental signal change probably indicates a worse prognosis. In addition, a low T1 signal also means a low prognosis because it indicates cavitation and cell loss. But overall consensus is forming that a mere presence of a signal abnormality is not an indication for surgery in the absence of clinical findings. And this systematic review found it exactly reverse, that the absence of T2 signal meant early myelopathy and presence meant late myelopathy. So this was very discrepant, so they did not give any recommendations. So to conclude, for mild myelopathy or asymptomatic patients, at present, we are personalizing treatment for the patient. As respect to surgical approach, it comes down to surgeon preference because complications rate differ. For total disc replacement, it works for some patients with myelopathy. Routine use of neuromonitoring, at least I am not doing it routinely for every patient. And radiological predictors, especially T2 signal change, is not like what we thought of before. Thank you very much.
Thank you, Kshitij. Hold your gun. We'll have question answers to you at the end of the 3 talks. That is how we have planned it. So next we have Professor Sumit Sinha. He needs no introduction, and he will be talking on another controversy just Kshitij pointed out, whether to go anterior or posterior when treating these cases of cervical myelopathy. Over to you, Dr. Sumit. You are muted. Please unmute yourself.
Can you see my screen now?
No, we cannot see it. It says
Yes.
double click the entry. Yeah, no, we can. Reshare.
Yeah, I'll do that.
Yeah, we can see your screen
And
now.
now you can see.
Yeah. Please go full screen.
Okay. So thank you very much. Yeah. Is that it?
It's still not full screen, but
Well, thank you.
go ahead. Please go ahead. Yeah.
If not full screen.
Still, we cannot see it full screen.
No?
Yeah. Now full screen. Go ahead, please. Thank you.
Okay. So at the outset, thank you for giving me this opportunity to discuss about my experience with this highly debatable issue. Now, we've been hearing debates and panel discussions on this very highly controversial topic. Whether what are the approaches, what are the natural history times in cervical myelopathy. Thank you, ASSI, and I would love to learn from my Japanese colleagues over that, because we all know that no one in the world, all over the globe, can have as much of experience as the Japanese. So at the outset, I would say that 8 minutes I have been allotted. I would try my best to summarize and sum up as much as possible about this problematic situation in which the consensus opinion is very, very difficult to make. So surgical approaches, there is a myriad of the operative approaches ranging from ventral cervical discectomy to corpectomy to laminoplasty, laminectomy, few we all know that. Now, what is the factor which decides about which approach to do or not? And I would rate as the most important is the surgeon's experience. If a surgeon is very well experienced in stick to the anterior approaches as much as the scientific evidence suggests to stick to approaches. If he's doing the posterior approaches, then as much as possible stick to the posterior approaches as the scientific evidence suggests. So, and what does the scientific evidence suggest? I will shortly elaborate in the subsequent slides. The second thing is the number of segments involved. Now, this is the another important factor which is important in planning the approach, whether to go from front or from back. How? I will just elaborate in my subsequent slides. Predominant location of the compression, whether it is from front. If it is from front, deal it from front. If it is from back, deal it from back. If it is from both the sides, it is prudent to deal from both the sides, from the front as well as back, in a 360-degree decompression. Cervical alignment. If the cervical spine has got a kyphosis, then it's not good to do posteriorly. It's always better to do a posterior decompression in the face of a normal contour or a lordotic spine. Instability, yes, it is prudent to fix it anteriorly as maybe plus minus a posterior fixation. So having said about this background, let's see as to what are the factors which determine what approach to choose in these patients. So regarding the number of segments involved, the patient has normal lordosis with ventral compression involving less than 2 segments. It is the ventral cervical approach which is the best approach for these patients. However, patients requiring 3 or more than 3 levels of corpectomy for ventral decompression, it is always better that if you are doing it anteriorly, always supplement, always augment the stability by doing a posterior fixation and achieving a 360-degree fixation. With 3 or levels or greater than 3 levels of decompression anteriorly, there is a high chance of graft failure rate, pseudoarthrosis, especially if an anterior plate with unicortical screws are used. So beware of doing this more than 3 levels or 3 levels. And if it is there, then go for a posterior approach. Now, the advantages of anterior approach, we all know that the ventral, it addresses the ventral pathology directly, it restores the normal cervical lodge, and the posterior approach, the advantages are the avoidance of the complications of the anterior approach, of course, and it is more suitable for doing it for more than 3 levels. The disadvantages are more for anterior approach. As we can see, the graft dislodgement, pseudoarthrosis, dysphagia, hoarseness of voice, dural injury, and leak. In the posterior approach, the predominant complications are higher risk of C5 palsy, which we will look into, and this is an indirect decompression. One has to know that, and it is always dependent on the posterior shift of the spinal cord after we remove the posterior elements. So my subsequent discussion will be only for the evidence regarding the choice of anterior versus posterior approach in those patients who require 3 or more levels of pathology in the CSM, and those patients with lordotic or neutral cervical alignment. So this is a specific subset of patients in which there is a highly controversial literature. Some say in favor, some say conflicting scientific evidence, in which my subsequent discussion will revolve around. Patients with cervical kyphosis, either global or segmental, especially if there is a fixed kyphosis, require a standalone anterior approach or a combined 360-degree approach. I already told so. So, however, the evidence in literature for or against anterior and posterior approaches should be discussed with respect to the following 10 parameters. I mean, I came across a beautiful article written by Professor Muthukumar from Madurai, and if this is I would certainly recommend to read for the readers this article, which is published in Progress in Clinical Neurosciences, and it is a summary of literature of on this topic, whether to go from anterior or posterior approaches. So in the literature, these are the 10 parameters by which the decision to operate whether go from anterior or posterior depends upon. And these are the long-term outcome parameters: the risk of inadequate decompression by any approach, the risk of reoperation, complications in general of the anterior vis-a-vis the posterior approach, radiological ASD and clinical ASD. Number 7 is the range of motion change post-operatively and the sagittal alignment post-operatively. Number 9 is the incidence of C5 palsy, and lastly is the post-op axial pain. So I don't have the time to quote the literature for all these things in these 8 minutes. I would certainly recommend the listeners to read about this in the various journals in the publication, especially by Professor Muthukumar. It's a wonderful article written by him in Progress in Clinical Neurosciences. And I will take you directly straight away to the comparison of these 10 parameters in these two approaches, anterior and the posterior approach. Now, what we see, if we scan the literature, what we see is that in the anterior approaches, all of these things are more as compared to the posterior approaches. And what are these things? This is the risk of inadequate decompression, risk of reoperation, complications, overall incidence of complications, radiological and clinical ASD, and ROM decrease. They are all more in the anterior approaches as far as the literature is concerned. However, the posterior approaches, they are a loser in these 3 parameters, like the sagittal alignment post-operatively, incidence of C5 palsy, axial neck pain post-operatively. And as far as the clinical outcomes are concerned, more or less anterior approaches fare as well as the posterior approaches. Now let's see what the randomized trials do we have, especially when this parameter is concerned, which approach to choose in CSM. I can find only 2 randomized trials here, one by El-Gandour, and this was the first prospective randomized trial published in 2020 in JSSR Spine, and the authors found that the anterior approach was significantly better regarding post-op pain, neck disability index, and hospital stay, while the posterior approach was significantly better in terms of post-op dysphagia and the operative duration. The second randomized trial was, of course, quoted by the previous authors, Zohar Gogawala group, and this was one of the beautiful trials published in JAMA in 2021, And the authors found that the ventral surgical approach did not significantly improve the patient-reported physical functioning at 1 year compared with the dorsal surgical approach. So this was a significant article which concluded the following things. So summarizing the literature and take home message to the listeners is that the choice of the appropriate surgical procedure should be individualized. It is not a one fit package for all, and it has to be seriously individualized for a separate patient altogether. So what do we come across with is a 3-level disease with segmental kyphosis and significant pre-op neck pain should undergo an anterior approach. Howsoever, a 3-level disease with a lordotic cervical alignment and minimal or no neck pain should undergo a posterior approach. So this is how is it, and thank you so much.
Thank you so much, Dr. Sumit. You did give us some clarity about, whether to go anterior and posterior. Now let us go into another hornet nest and introduce our next speaker, who is another accomplished neurospine surgeon, Dr. Umesh. And he either is going to give us a clarity about what approach to be used when we go posterior, or we are going to get more confused because literature is such that there is no clear-cut answers. And we would later on want our Japanese experts to comment on this. Dr. Umesh, over to you to let us know whether we should do a laminectomy alone, whether we should do laminectomy and fusion, or laminoplasty is a gateway option. Over to you, Dr. Umesh. Umesh, can you hear us?
You can see your screen. Yeah.
Okay. So
Okay,
thank you so much, Niraj, Ayush, and I'm very honored to be a part of this alike panel. So I'll just jump into the topic. Dr. Sumit has already told that posterior approaches are better than anterior approaches for multi-level as well as for a lordotic spine. So my job here is to tell about which of these 3 approaches are, how they compare against each other as far as we deal with the posterior approaches. The claim that each of them make is very simple, very clear cut. The laminectomy says that it's a very simple, fast, less complication surgery. It's a low-cost surgery, preserves the motion, but there are problems with post-op axial pain, post-laminectomy kyphosis, post-laminectomy membranes, which may lead to higher reoperation rates. Laminoplasty claims to overcome these disadvantages, maintains the alignment better, prevents the post-laminectomy membrane formation. It maintains motion and natural biomechanics while preserving posterior elements. But there are issues, again, with progression of pathology, especially if it's OPLL. There are reports of significant axial pain even after laminoplasty, and sometimes it can be considered technically more challenging than the other 2 procedures. Laminectomy and fusion is considered to reduce the progression of primary pathology, is considered a more definitive, complete surgery. It preserves the spinal alignment, prevents progression of kyphosis, and it claims to have a good long-term outcome. But however, there are disadvantages of loss of motion, adjacent segment stress. It requires a longer operative time, more cost, and probably a higher complication rate as well. So let's go into the literature. It's not that simple. So I've tried to be as brief and as, to make it more clear as possible, and divided them into these 3 categories. How these three surgeries fare when we compare the clinical outcomes, whereas as compared to the pathology that we are dealing, as well as the cervical alignment, if you consider. So coming to the first thing, that is the clinical outcome, studies that have shown or compared only laminectomy versus laminoplasty have shown that there is no clear benefit of laminoplasty over laminectomy. And, this is one of the retrospective studies. And even laminoplasty for more cervical levels was associated with axial pain as compared to laminectomy as well. Though both these groups had a similar loss of sagittal alignment. However, there are studies that show that a long-term outcome is better or favors laminoplasty in terms of JOA and NDI scores. And even these 2, review of systematic review as well as a meta-analysis, which shows, similar group of studies over different periods of time, which shows that RM is better in laminoplasty as compared to laminectomy. The claim of superiority for laminoplasty is not justified, and there were no differences in the clinical outcome between the 2 groups. surprisingly, post-op cervical lordosis was better after laminectomy, and there were no clear-cut guidelines for choosing either of these procedures to treat cervical spondylotic myelopathy. However, a recent review of literature, 19 studies, 3 randomized controlled trials, 16 observational studies, a large group of patients did claim that, what we tend to believe, that laminoplasty is, better in terms of less operative time and blood loss. It's lower incidence of a nerve complication, lower infection rates, better NDI scores over a long term, and it should always be favored over laminectomy whenever there is no instability. Does addition of fusion help in laminectomy compare better with laminoplasty? Probably this is the only prospective randomized controls trial that we found. It says that there are significant improvements in pain measures in the laminoplasty group is there, but the restoration of spinal canal area was superior in the fusion group. Again, meta-analysis, multiple studies over almost a similar period of time, which shows that though the long-term outcome was favorable in the fusion group, the higher complication rate was noted. Again, fusion group is associated with a higher incidence of opioid use than the laminoplasty group. And of course, it also has increased rates of adverse events, readmissions, increased length of hospital stay. This is one of the largest studies that compared, a large group of patients, the American College of Surgeons, between laminoplasty and laminectomy as well as fusion. And this is, again, a similar study, 2 different authors, same journal, same issue, just one article next to the other, all obviously came out with similar conclusions, telling that even though the clinical improvements are similar, the incidence of nerve root involvement or nerve root complication is higher in the fusion group, and laminoplasty has got a better range of movement post-operatively. It has got a lower blood loss, shorter operative time, as well as lower overall complication rates. Now, there are studies which say that fusion is better in patients who have higher preoperative axial neck pain. But however, this is one of the studies which shows that in laminoplasty group, not only the return to baseline activities as well as improvements in neck disability was higher, but a moderate preoperative neck pain improved even after laminoplasty, and that may not necessarily be a contraindication for laminoplasty. What about the pathology? How does pathology fare when we compare these 3 techniques? So this is again, it compared the 2 techniques, that is outcomes after laminoplasty, laminectomy, and fusion. Again, it's concluded that for myelopathy, for spondylotic myelopathy, laminoplasty and laminectomy and fusion groups are similarly effective, but however, the evidence regarding effectiveness of either procedures is insufficient as far as OPLL is concerned. And which one to choose? Whether the laminoplasty or laminectomy and fusion, the evidence is again insufficient. However, the question comes in whenever we consider OPLL about the progression, and studies have clearly shown that after laminoplasty, the rate of progression of OPLL is significantly higher, 70% over 3 to 10 years time, as compared to laminectomy group, where the OPLL progression was nearly 7 times faster with laminoplasty as compared to a laminectomy group. In that particular study, similar findings were echoed by several other studies as well. But does this really translate into clinical deterioration? So even though there was a 62% rate of OPLL progression of after laminoplasty, the incidence of clinical deterioration was not significantly higher. But even after this meta-analysis concluded that probably the duration of follow-up in these cases, even though it was 10 years, probably over a period of time, the OPLL progresses significantly to cause more neurological injury. And that is why laminoplasty may not be recommended for OPLL patients. And this is what this study came out with. And again, this is a large comparison, 24 studies, radiologic OPLL progression was significantly more after laminoplasty, but however did not correspond with neurological deterioration, as we already know. So how about cervical alignment? How does it play a role in the decision-making process? And here we already know that laminoplasty clearly preserves motion to a significantly higher degree as compared to laminectomy and fusion. There is a good change in the alignment as well as range of movements post-operatively. More number of patients develop this buckling type of alignment, the malalignment after laminectomy. Nearly 1/3 of the patients after laminectomy develop this kind of alignment as compared to laminoplasty. And however, this study shows that even the outcomes of laminoplasty are significantly better if the cervical lordosis is preserved. So that means that with progressive loss of cervical lordosis, even after a laminectomy or laminoplasty, or the outcomes or the outcome after laminoplasty significantly reduces as the cervical spine progressively goes into kyphosis. It's been clearly shown that in patients who have SVA more than 40 millimeters, neck pain significantly increased after laminoplasty, but was stationary in the laminofusion group. And laminoplasty should not be recommended for a K-line negative OPLL. So evidence is clear that it's not very clear if these myelopathy groups as considered as a single group. But however, cervical myelopathy is not a homogeneous group. There are varying different categories, different variables that we have to consider in a stable lordotic or a neutral spine where laminectomy and laminoplasty are the options. Evidence slightly favors laminoplasty. In OPLL, cervical spondylotic myelopathy, if the spine is lordotic or neutral, all three procedures come into picture. Evidence slightly favors laminoplasty in cervical spondylotic myelopathy, but however, there are more studies which say that the long-term outcomes are better in OPLL after fusion as against in cervical spondylotic myelopathy. However, one thing is clear: in K-line negative unstable SVA more than 4, higher axial neck pain, evidence clearly favors laminectomy and fusion. And that is why individualized case-based discussion should be there, considering all the above factors. And this is something that Dr. Sumit also told. It's not evidence-based medicine is not just reading and following what is there in the literature. We should consider the other factors as well. Thank you so much.
Thank you, Umesh, for such a nice description and the review literature. Now we will have the first three speakers can take the question. We can have any question for Kshitij, Sumit, Dr. Sumit, or Umesh. If you are one of the panelists, you can just directly pose a question. If you are a viewer, put it on the chat. Timing, let's start with Kshitij. Kshitij, you told that you don't use neuromonitoring for all your cases. Which are the cases where you feel they are the must?
Okay, so one is any patient where I'm going to do a deformity correction definitely gets neuromonitoring. So basically, it's like cervical kyphosis, or even if it is a flexible cervical kyphosis, you're making the patient prone, and you're going to change alignment of the cervical spine, or for that matter, somebody getting anterior, posterior, multi-level corpectomies is another situation where I will get neuromonitoring done. Then sometimes it is kind of an intuition. I don't have kind of a strict thing. These were the ones where it is clear that we'll use neuromonitoring, but there are some situations where I would prefer, like for example, not all OPLLs, but maybe some OPLLs, definitely the ones that look really bad. And I'm going to go in the front, and maybe some people might argue that if injury is going to happen, you're just going to detect it intra-op and nothing else can change. But I think a lot can be detected by neuromonitoring. Means if you don't know that you are causing damage, then you will continue to cause damage and make a reversible part irreversible. So maybe in those situations also I might and I have used neuromonitoring in the past. Whether it has helped me reduce my complication rate, that's a different matter. But yeah,
I completely agree with you. At least it makes you slow. It's like a warning sign. Once in a while, you just take a break. Maybe it gives some more time, and it's very difficult.
I have had a patient where I had to abandon the surgery. Like for example, we were going to do the surgery. The baselines were good. Then the patient was put in traction. We lost the signals. we couldn't get the signals back after the repositioning and blood pressure changes and all those things. We had to literally wake the patient up. Then the patient was moving his legs after waking up the patient. And then we said, just let's come back on a different day. And then we did the surgery on a different day. So I don't know whether this is kind of a problem with neuromonitoring, but I think it was a real thing because we had baselines and the traction changed something.
So what I know is for most of the Japanese hospitals, they do neuromonitoring for all their cases. That is my understanding. So do you have any different take? Anyone like to put in a comment? What I saw, I was with Dr. Masato Tanaka, and we saw their neuromonitoring all their cases for everything. Do you guys have a different take? Any one of you can just, Dr. Takahata, can you just take it? What is your take on neuromonitoring for these cases? Do you neuromonitor all your cases?
Yeah, we don't use neuromonitoring in all the cases for such as laminoplasty or some not difficult surgery. We don't use it. So, but I totally agree with you. When we do the deformity correction, so it has a high risk for neuro injury or some complications. So in that case, we use the neuromonitoring. So speaking of neuromonitoring, so do you think you can detect the C5 nerve palsy? So do you have any special idea to detect the C5 palsy during the surgery?
What little I have seen is normally they don't happen on the day of surgery. Most of the time they are, you find them after 24, 48 hours. And at least whatever little I have done, I never got a chance to detect them intraoperatively. Dr. Sumit Sinha, your take, and you have a question or a comment, please.
Yeah. Regarding first question, regarding this IONM controversy, see, I mean, if you ask me, then I use IONM in my all cases as a routine. So there is no question other than a small maybe anterior cervical discectomy procedure. Otherwise, I use routine monitoring in my all cases. Now, the reason why I do it is because not only that it warns you preemptively about the possible damage that might be caused by even a subtle maneuver of patient positioning on the table prone or by applying a traction, as very rightly said by Dr. Kshitij. But you come to know beforehand in these cases, and you can take preemptive measures, corrective measures, which are very, very important, and you can save your patient from a possible disastrous complication when he wakes up after the surgery. So even if you get this complication in 1 out of 1,000 of your operated patients, it would carry a big blot on your name, and you will repent it forever. So I always do it for this reason. Now the controversy is about whether you can prevent it or not. So the neurological deficit. So certainly we cannot prevent it from happening, but we come to know in time, and we can employ corrective measures to prevent it from getting permanent. Like, for example, we can ask the anesthesiologist to raise the blood pressure. We can wait for some time. We cannot, we stop the dissection at that point of time for a certain period of time till the time they recover. We employ the D waves. Now, if the D wave is also gone, now this is a potential disastrous event that has happened in your surgery, because D wave, if it is gone, then this means that this is a probably injury to the corticospinal tract, which can be permanent also. So I don't remember in my career that I have to wake up the patient for any time, but certainly I have stopped during my surgery quite often, especially in intramedullary tumor surgery, as directed by my neuromonitoring neurophysiologist. So it is an important thing which everyone should have.
Thank you so much. And before we move on, one last question to Dr. Umesh. We have a question on the chat group, and it asks, how long can you expect, like for how long do you expect for the myelopathic sign and symptom to resolve after surgery? Do you think there's a timeline? Anything you can predict? What do you tell your patient when they come to you for surgery? It will take 3 to 6 months. What do you tell them?
I honestly tell them that I don't know. So it varies a lot. It varies on a lot of factors, and it's very difficult to predict in a particular patient how much the either the radiological signs are going to regress or how much the clinical myelopathic signs. If they're mild myelopathy, shorter duration, there is a very good chance of improvement and in a shorter while. But the longer the myelopathic symptoms, the more severe the myelopathic symptom, once it reaches NURIC 4, 5, in those cases, the chances of recovery are delayed. The chances of recovery may be incomplete. And sometimes, we can't exactly predict how the recovery is going to pan out in these cases. So I think it's not such a simple question that we can answer in as a homogeneous thing that this is what happens all the time. That is what I feel.
Thank you, Umesh, and thank you, our speakers. For the sake of time, let's move on to the next speakers. Anyone has anything to ask? Yeah. So let me introduce Dr. Tamai, if I pronounce your name correctly, and he will be talking on multidisciplinary approach following surgery for cervical myelopathy. Over to you, our Japanese friends.
Thank you, Dr. Sharma, for introducing me. And very nice to see you in old Indian surgeon, spine surgeon. This is Koji Tamai from Japan. And let me share my screen. All right. I'd like to introduce new approaches following surgery for cervical myopathy. It might be a completely different perspective from a previous discussion about how to approach and the surgical approach. Okay. I have, this is a disclosure. I have received a grant from the private foundation to support this study. And cervical spondylotic myopathy is the leading cause of spinal cord impairment worldwide. Surgical decompression with adequate timing and postoperative professional rehabilitation are the standard treatment strategies that alleviate disease progression and improve neurological function and QOL. Our team have studied about the QOL change after surgery for CSM and published several papers in these 2 or 3 years and found that social functioning is key for QOL improvement of the patient. Social functioning is defined as an individual interaction with the environment and the ability to fulfill the role within such environments as work, social activities, and relationships with partners and family. For example, you can see 3 pictures now. When you see this elderly man's social functioning, it might be the working with his wife and dog. That would be the activity with his environment in his family. When you see this pictures elderly man, his social functioning would be the playing with and taking care of children in his environment or in his society. That might be the social functioning of him. And finally, these guys might be a golf with his friends. That might be the activity of his social functioning. So the social functioning would be the key to improve the QOL after the surgery for the cervical spondylotic myopathy. And another perspective is the approach. In general, the surgeon, therapists, nurse, and medical staff might be the key player to treat the cervical spondylotic myopathy. But in general, both of them, these 3 professionals provide a professional works independently. So in Japan, I do the surgery and ask the therapist to have the rehabilitation. That's it. So that we do not ask any other one. So we hypothesize that adopting a postoperative multidisciplinary approach for improve or rebuild the social functioning of patients with CSM may lead to further QOL improvements postoperatively. For example, this is just an schema. So that we hire the clinical psychologist, and clinical psychologist has an interview before surgery to decide the social functioning of the patient. And patient, surgeon, the clinical psychologist, patient's family and friends, nurse and medical staff, and therapists share the social patient's own social functioning to achieve the social functioning improvement after surgery. For example, when we define this old guy's social functioning as a fishing with family, his family, the therapist used fishing tools such as lures in the training. And therapist and nurse recognize the route for fishing and share the risk with family. And surgeon like me check the progress of his goal during every patient's visit. And all related professionals have meeting every 2 weeks to see the progress. So the aim of this study is to aim to identify the effect of the multidisciplinary approach to the social functioning on the one-year surgical outcome of patients with cervical myopathy. And this is the settings that we have a control and the social functioning group. Control was performed underwent laminoplasty for cervical spondylotic myopathy between 2018 to 2020. And standard rehabilitation was performed for 6 months. In the patient with the social functioning group who underwent laminoplasty, we underwent laminoplasty between 2021 to 2022, and the multidisciplinary approach was performed for 6 months after surgery. And we have found 140 cases in controls and 31 cases in the SF, a social functioning group. There is no significant differences in age, sex ratio, and preoperative JOS score. And this is a result, surprisingly, the social functioning group demonstrated the higher improvement of the JOS score. And also the upper extremity function of the JOS score showed significantly higher in the social functioning group comparing to the controls. And this is also, the results were also validated by the patient-reported outcomes, including the JOS-CMEC, which is the upper limb function was showed a higher, significantly higher score in the social functioning group compared to the control group. And finally, the EQ5D5L showed the higher score in self-care domains in social functioning group compared to the control group. So in summary, the multidisciplinary approaches to social functioning rather than an independent professional approach was effective in improving cervical myopathy and a part of the QOL after surgery for the CSM. Our study has also had a limitation. The enrollment time of the social functioning cohort was relatively long. The number of patients in the social functioning cohort was relatively small. And the patient in the social functioning cohort, but not those in the control cohort, underwent several interviews by a clinical psychologist. However, we could say that this prospective cohort study revealed that the multidisciplinary approach to improve the patient's social functioning was effective in improving cervical myopathy and self-care domain of patients' QOL. This study is the first to demonstrate the effectiveness of a post-operative multidisciplinary approach in patients with CSM. Thank you for your attention.
Thank you so much, Dr. Tamai, for sharing such a nice work which you have done. And we'll move on next to Dr. Takahata, who will be talking on the treatment strategy for myelopathy due to retroodontoid pseudotumor in the elderly. Over to you.
Okay, good evening again. My name is Masahiko Takahata. I'll be speaking to you about the pathogenesis and the treatment strategy of non-rheumatoid retroodontoid shoot tumor in elderly. So this is my disclosure. So let me begin with the epidemiology of non-rheumatoid retroodontoid shoot tumor. although the exact prevalence of NLP remains unknown, it is an increasingly recognized as a cause of cervical myelopathy in elderly. So according to our surveillance study on causative diseases of upper cervical spine surgery in Hokkaido Prefecture of Japan, the percentage of rheumatoid arthritis has dramatically decreased, where the percentage of NLP has increased. So several surgical strategies have been proposed for NLP, so such as resection of the pseudotumor through the anterior transoral approach or posterior extradural or transdural approach, and the C1 laminectomy without fusion, and occipitocervical and atlantaxial arthrodesis surgery. However, we have yet to reach a consensus on surgical strategies against NLP. So I think there are two main reasons why there's no consensus on surgical strategy for NLP. So one is challenge in directly removing a pseudotumor, especially in the elderly. And the second is diverse underlying conditions for NLP. So several congenital and degenerative factors may contribute to the development of NLP, suggesting that the optimal surgical strategy depends on each pathology. So to establish an appropriate surgical strategy for myelopathy caused by NLP, so we first investigated the underlying conditions of NLP by comparing radiographic characteristics of NLP patients with those of age and sex-matched controls. Next, to clarify the efficacy of each surgical procedures, we retrospectively compared surgical outcomes between procedures. So to clarify the radiological characteristics of NLP, we performed retrospective case control study on 35 patients, 35 NLP patients who underwent surgery, and on 70 age and sex matched patients with degenerative cervical spondylotic myelopathy. So an average age of patient with NLP were 76 years old, and we evaluated possible radiographic factors associated with the development of NLP. So according to radiographic evaluation, we could find several possible factors associated with the development of pseudotumor. So the factor most likely to be associated with the development of pseudotumor is a greater C1-2 movement compared to age and sex matched controls. As you can see, an NLP group showed greater C1-2 flexion extension ROM and ADI at neck flexion position. So, however, it is noteworthy that most NLP patients did not have growth instability at C1-2. Only 20% of the NLP patients were judged to have atlantaxial instability, and the ADI was only slightly enlarged, averaging 3 millimeter. So, an interesting finding was that, contrary to our expectations, patients with NLP have had less osteoarthritis change in the Atlant dense joint compared to controls. So when we take a closer look at the changes in the Atlant dense joint, we found that more than half of the patients in the control group had moderate to severe OA in the atlantaxial joint, Atlant dense joint, with an ADI of 1 millimeter or less, while many of the NLP patients had mild OA with an average ADI of 3 millimeter. So for ADI at neck flexion position, we can see a weak but positive correlation with pseudotumor size, suggesting that the ADI is associated with a pseudotumor. However, this fact does not necessarily suggest that C1-2 instability induces a large pseudotumor, because it is possible that pseudotumor may develop to the Atlant dense joint, inside the Atlant dense joint, and expand ADI. We also investigated the mobility and alignment of the subaxial cervical spine as an indirect factor in the development of pseudotumor. As a result, we found that NLP patients have less mobility of C27, which results in relatively greater mobility of the upper cervical spine, and that hyperlordosis of the subaxial spine is also a risk factor for developing shield tumor. So then we performed multiple regression analysis and found that the expansion of the atlas dense joint and subaxial ankylosis and the C7 tilt were significant risk factor for the development of shield tumor. So we also examined the gender difference. So what we found was that OC1 mobility was poorer in female patients than in a control group. So, but this trend was not observed in male patients. So I should also mention that C1 hyperplasia may contribute to the development of myelopathy due to NLP. So patients with NLP had an average C1 surgical inner diameter of 30 millimeter, which was significantly smaller than that of control patients. So this slide shows surgical outcomes of 3 procedures. Among 31 patients who could be observed more than 2 years, 11 patients underwent OC2 fusion, 6 underwent C1-2 fusion, and 14 underwent C1 laminectomy alone. The neurological recovery was improved regardless of the surgical procedures, but fusion surgeries tended to show superior recovery rate. An MRI showed spontaneous shrinking of the shield tumor regardless of the procedures, but the fusion surgeries tended to show superior shield tumor size reduction. So one important finding was that cervical spine motor function was found to be significantly worse with OC fixation, especially in patients with subaxial ankylosis. So in conclusion, shield tumor can be induced by supraphysiological stress on the atlas dense joint, resulting from ankylosis and hyperlordosis of the subaxial cervical spine. Therefore, arthrodesis surgery is an effective surgical strategy for myelopathy caused by NLP. However, the indication of OC fusion should be carefully determined for patients with ankylosis of the subaxial spine because it results in a remarkable loss of cervical motion function. So the development of myelopathy is attributable to C1 hyperplasia in approximately 30% of our cases, indicating that such patients could be treated by posterior decompression alone. So thus our study suggests that C1-2 arthrodesis surgery or C1 laminectomy alone would be a reasonable surgical strategy to treat myelopathy caused by NLP in elderly patients. Thank you for attention.
Thank you, Professor. So moving ahead, we have Dr. Kitamura, who will be talking on muscle-preserving potential dilemma in posterior decompression surgeries for cervical myelopathy. Over to you, Dr. Kitamura.
Hello, everyone. This is Mikazu from National Defense Medical College. Let me share my screen. Can you hear me, and am I sharing my screen?
We can hear you. Your screen is still not visible.
Okay.
Now we can see your screen.
Okay, thank you. So today's my talk is muscle preservation in posterior decompression surgery of the cervical spine. I have nothing to disclose. So today, let me share with you first the history of laminoplasty, because I believe it's extremely important to understand why laminoplasty was invented. And then I share with you the favorable outcomes after laminoplasty. And in the last, I talk about the muscle-preserving selective laminectomy, a less invasive alternative for laminoplasty, and explain why we need to pay attention to muscles. So up to 1960s, the decompression surgery of the cervical spine was well established in anterior approach, as you know. However, the only one solution in posterior approach was conventional piecemeal laminectomy. So this is a very old Japanese literature back in 1972 by Dr. Kirita from Kyoto University. He treated a patient with severe myelopathy by OPLL with high occupying ratio and reported what happened to the patient. And the dural tube, together with the spinal cord, swollen up to the space made by the first laminectomy, and the spinal cord was compressed very severely at the residual adjacent lamina, followed by further compression by another laminectomy using bulky rondules, which severely damaged the spinal cord, resulting in severe tetraplegia and respiratory failure and even death. So Dr. Kirita reached out to the concept that simultaneous multi-level decompression is mandatory for safe and secure decompression. And what he did was thinning down the lamina using rondule followed by high-speed burr and split them all together in the middle and decompress the spinal cord. So this technique, named extensive simultaneous multi-level laminectomy, was a game changer and significantly improved the surgical outcomes. However, the width of decompression was very wide enough into the pedicle, sacrificing multi-level facet joint, so progressive postoperative kyphotic deformity was very frequently observed. And this kind of deformity and the vulnerability of the widely exposed spinal cord remained as unsolved problem, which led to the invention of laminoplasty in 1970s afterwards, preserving bony anatomical structures in the posterior cervical spine. And here are a variety of laminoplasties invented after 1970s, and these laminoplasties can be grouped into two fundamental concepts. So the first one is open door by Dr. Hirabayashi, and the other one is double door by Dr. Kurokawa. And favorable long-term outcome after laminoplasty have been reported in patients with both OPLL and cervical spondylotic myelopathy, as you can see here. And the key to obtain a good outcome after laminoplasty is to select good candidates for posterior decompression according to a variety of preoperative radiological indices, as you know. However, the progressive post-op kyphotic deformity still remains unsolved, even when you perform laminoplasty, leaving the bony structure in the posterior cervical spine. And in these cases, the remarkable muscular atrophy is very frequently observed on postoperative MRI. And several attempts have been made to predict post-op kyphotic deformity after laminoplasty. And interestingly, preoperative poor ability of the neck extension was identified as a risk factor for postoperative kyphotic change. So these studies are suggesting the importance and the significance of the ability of neck extension. So when we look at the neck extensor muscles, so the deep extensor muscles, the semispinalis, multifidus, and rotators directly attach to the spinous process and stabilize and mobilize the neck. However, in this kind of conventional posterior approach, these muscles are always removed from spinous process. So muscle-preserving selective laminectomy was proposed by Professor Shiraishi. So we first spread the free space between the bilateral interspinalis and keep this space open and split the spinous process down the middle and divide the spinous process at its bottom. And then expose the lamina and decompress the spinal cord. And note that throughout this procedure, the muscle attachment at the spinous process is kept undisturbed. And when we go down to the lamina, we can find that the multifidus and rotators originate from the lateral mass. So we performed a cadaveric study to investigate how the multifidus originate from the lateral mass. So we can find that the multifidus and rotators firmly cover the lateral mass and the facet joints. And here the multifidus attaching to C2 and C3. And when flipped like this way and observed from inside, we can find that multifidus and rotators had their origin very widely on the lateral mass from C5 down to T1 transverse process. So If we expose the lamina laterally to the lateral mass, unfortunately, these two muscles are damaged both at their origin on the lateral mass and at their insertion on the spinous process. So it's very easy to imagine that these muscles goes atrophic even after the conventional, normal, usual posterior approach. So when we look at this area more carefully, we can find a kind of membranous tissue surrounded by the yellow line, like here, and this attached directly to the ventral aspect of the mouth fetus. And beneath this tissue, we found that facet joint space is already open. And the similar findings was confirmed by the histological analysis, and the lateral half of the facet joint space was covered by a fibrous capsule. However, in the medial half, the joint space was not covered by the fibrous capsule. And this is another type. The lateral half was covered by a very thick layer. However, the medial half was covered only by a thin fibrous layer. So these findings are suggesting that we can easily and unintentionally sacrifice the muscle origin of the lateral mass and sacrifice the facet capsule only by dissecting the muscles laterally to the lateral mass. So despite this fact, cadaveric study performed by Dr. Zdebrik clearly reported that strength and stability of the facet joint reduced only by resecting capsule, only capsule, more than 50%. However, for these procedures, the wide exposure is always required far beyond the medial border of the facet joint laterally onto the lateral mass. So in the muscle-preserving selective laminectomy, another point is to limit the width of the exposure. The width of laminectomy is decided as 2 to 3 millimeters wider than the spinal cord on preoperative MRI, and the lateral exposure is strictly limited well inside the medial border of the facet joint, preserving the muscle origin on the lateral mass and the facet capsules. And this is the basic concept for the decompression. So the concept of 2 levels decompression is accomplished by a single laminectomy. So this is the intraoperative pictures and the cartoon. And in this case, we don't hesitate to remove consecutive multiple lamina in cases with developmental stenosis and OPLL, where the patient has a stenotic lesion even at the vertebral body level. And this is the intraoperative video of C5-6 muscle-preserving selective laminectomy for consecutive 3 levels decompression. And this is rostral, caudal, and right and left. So start with spreading the free space between the bilateral interspinalis, and keep this space open using the retractors, and then split the spinous process down the middle without detaching its attached muscle. So we go down to the lamina and divide the spinous process at its bottom. So now the right half is being divided, followed by the left side, and same procedure is done onto the C6 spinous process and expose the lamina. And look at this picture. We can never find even the medial border of the facet joint. So facet joint will never appear in muscle-preserving selective laminectomy. This is the exposure of muscle-preserving way. And then do confirm the width of the decompression and remove the lamina as you want. So we use the high-speed burr and thin down like this way. And C5, followed by C6, and then confirm the width of decompression again, followed by the partial laminectomy of the rostral part of the most caudal lamina, in this case C7, and then split the spine, the thin down the lamina and the flavum all together in the middle, like the Dr. Kirita's way, and remove them. And this is the final step to remove the most rostral flavum, in this case C45. So the C45, 5, 6, 6, 7 consecutive 3 levels decompression is accomplished. And here are a variety of advantages of muscle-preserving selective laminectomy compared with laminoplasty to provide a comparable recovery rate with less post-operative neck pain and much less intraoperative blood loss and much lower incidence of C4 palsy due to the limited width of the decompression. And this is the most noteworthy part, the preservation of the cervical lordosis and range of motion even after multi-level decompressions. So when compared with anterior decompression and fusion surgeries, the muscle-preserving selective laminectomy also provided a similar patient-reported outcome measures improvement with less complications and with much better cost effectiveness because no metal instruments are required for laminectomy. So when your primary purpose is decompression, posterior decompression of the spinal cord, you don't need to stabilize the cervical spine using expensive metal instruments after taking all the trouble to destabilize the spine by removing the muscles. All you have to do is preserve the muscles, both at their origin and in insertion, and remove lamina. So go with muscle-preserving selective laminectomy. So in summary, muscle-preserving selective laminectomy is a less invasive and cost-effective alternative for the laminoplasty and can potentially demystify dilemmas of the laminoplasty. Thank you for your kind attention.
Thank you so much, Professor. And moving to the last talk in the series, we have Dr. Takahashi, who will be talking about correction surgeries for cervical myelopathy. Over to you, Professor. Please unmute yourself. You are still muted.
Thank you for introduction. It's very great opportunity to speak here. So I'm talking about the correction surgery for cervical myelopathy, focus on dysphagia after correction. So dysphagia after cervical spine surgery is a common complication, especially in anterior cervical spine surgery, but also in the posterior occipital cervical fusion. The dysphagia is a very common complication after surgery, and the OC2 angle is reported as a risk factor. So how do we determine the correction degree in OC fusion? The OC2 angle is well known index and plays an important role in the development of postoperative dysphagia after an OC fusion procedure. The OC2 angle is easily measured during surgery and can be a practical index with which to avoid postoperative dysphagia. So this is the OC2 angle is associated with the narrowest oropharyngeal airway space. The change in OC2 angle less than -10 degrees showed increased risk of dysphagia after surgery. So this case is vaginal investigation and shows instability between occipital cervical spine and shows the retroodontoid shoot tumor. The case underwent OC2 fusion. The OC2 angle changed from 9 degrees to 3 degrees, which is more than -10 degrees. So the case shows normal swallowing function after surgery. What about C1-2 fusion? Recently, postoperative dysphagia is reported as a common complication even in C1-2 fusion surgery. The change in the preoperative and postoperative angles of OC2 and C1-2 angle may be the independent risk factor for postoperative dysphagia. The good alignment of lower cervical spine C1 to C27 low doses can prevent postoperative dysphagia. When creating an operation plan, the surgeon should pay attention to the change in the alignment of the craniocervical junction area in order to avoid alignment over changes during operation, and maintain OC2 and C1-2 angle in the normal range to prevent postoperative dysphagia. This illustration shows the possible mechanism of dysphagia after upper cervical spine fixation without involvement of the occipital bone. A larger soft tissue space between the C1 posterior arch and the occiput is achieved as the C1-2 angle is more natural or lordosis. This could improve trisomies and dysphagia by giving the skull, mandible, and the pharynx more space to be moved. What about subaxial correction? Fusion surgery and increased cervical lordosis after surgery are also reported as risk factors for development of dysphagia after subaxial cervical spine surgery. Cervical alignment change due to anterior and posterior fusion surgery can cause postoperative dysphagia. I'd like to share the one case. This 60-year-old male with history of 40 years of dialysis underwent laminoplasty in 2018. But myelopathy gradually worsened and deformity also developed. Correction surgery was scheduled. As previous report mentioned, the change in cervical lordosis would be risk for dysphagia. So I performed gentle reduction from 2 degrees to 5 degrees lordosis. Immediately after surgery, the muscle strength worsened temporarily. So the rehabilitation was started at P.O.D. 1, but his condition suddenly turned for the worse at P.O.D. by aspiration pneumonia. The treatment for pneumonia in the ICU lasted for 2 weeks and achieved improvement. But his condition deteriorated again after restart the meal. So this is the swallowing contrast exam revealed the retention of contrast agent in the pharynx, indicating impaired swallowing function and posing a risk for aspiration pneumonia. So he could not eat meal at all. So what should we do to treat the dysphagia? So should we choose observation or should we perform revision surgery to decrease the correction degrees? So, but I choose just the observation because I consider the correction was not too much. And fortunately, his dysphagia gradually improved and he could take any meal now. This paper from Japan in 2023 analyzed pre- and post-operative swallowing dynamics kinetically and investigating factors associated with post-operative dysphagia in patients with cervical degenerative disorder. Dysphagia severity scale was significantly worse post-operatively than preoperatively, not only in anterior approach, but also posterior approach. So each approach may decrease swallowing function, especially because of the limitation of anterior hyoid movement. I considered there were 2 potential causes. First, subclinical dysfunction of swallowing had already existed before surgery in this case, and worsened after posterior correction surgery. As another reason, the extension of the distance between lower jaw and the sternum might be associated with hyoid movement. There are 4 infrahyoid muscles and 4 suprahyoid muscles. The infrahyoid depress the hyoid and the suprahyoids elevate the hyoid bone. So in this case, the overstrain of the hyoid muscle group triggered the pull-down fixation of the hyoid bone, which led to impaired elevation of the larynx during swallowing and difficulty in closing the epiglottis. Eventually, this resulted in dysphagia. The chin-down maneuver is a postural technique widely used in dysphagia treatment. So the hyoid and laryngeal movement disorder being caused by the extension after surgery can be the mechanism of dysphagia. So the assessment of dysphagia before surgery and or halo birth in the case with the impairment of the swallowing function are key to avoid dysphagia. So in conclusions, dysphagia is associated with OC2 angle, C1, C2 angle, and C2-7 angle. Changing lower jaw sternum distance might be associated with dysphagia. Thank you.
Thank you so much. And this brings end to the second talks. We have already concluded all the 4 talks, and the forum is open for discussion. If you have any question from any of the faculty, you are most welcome to ask. The chat book box is open for any visitors who want to ask questions. Time being, let me start with Dr. Tamai, please. So very nice paper, and we understand that you are muted. Please unmute yourself. Yeah. So basically, we understand that multidisciplinary approach indeed is a better way. But in your study, did you find it very acceptable for the patients to adopt the multidisciplinary approach? And the other thing, did you do any cost benefit analysis when you are treating them to a multidisciplinary approach?
Thank you, Dr. Sharma. Yeah, so that we also surprised about our results. So that we hypothesized initially that our multidisciplinary approach might provide a higher QOL improvement, but in the results, we could also get myopathy improvement itself. So that it was a so surprising result. So we hypothesized that motivated rehabilitation might be accelerated in the multidisciplinary group, multidisciplinary approach group, but it is up to discussion. Thank you.
Okay, thank you so much. And coming to the next speaker, Dr. Takahata. So when it comes to pseudotumor, what is your best approach? Do you think maybe what we can get out from your study, maybe a fusion in terms of C1, C2 is the best thing? If it is possibly done, that is the best approach which can be done?
Yes, C1-2 fusion is a best procedure for the NLP, I think. So based on our study, but the patient with NLP is elderly. Average age of these patients are 76 years old. So sometimes the condition of some of these patients are not good. So in such case, we sometimes select C1 laminectomy alone. So because it takes maybe 20 minutes or 30 minutes, so it decreases the risk. So
okay, thank you so much. So, and for Dr. Kitamura, Kshitij has a question. Is there any situation where you cannot do a muscle preserving laminectomy, like if
thank you.
Treat spine or kyphosis?
Yes, it's
so
very.
What are your takes? What are the please
the
go ahead.
contraindication, the limited indication for this technique. So now actually we are working on it to make it clear. But so far, I'm following the similar preoperative indication for the laminoplasty. So maybe the 13 degrees kyphosis is reported by Professor Suda from Hokkaido, and I'm still following that indication. But I do expect that the muscle preserving way will or can allow more kyphotic patients, because the muscle preservation has more ability to maintain the cervical alignment even after the posterior decompression. And one paper reported that the 14.5 kyphotic alignment might be a cutoff value to accept to provide the acceptable neurological recovery after muscle preserving selective laminectomy. However, Yes, I think so far it still remains unclear. But personally, I'm following the similar indication for the laminoplasty.
Thank you so much. And for the last speaker, it's very, very interesting. You know, we never realize, you know, you can have problems with the alignment once you change the alignment. So does your study, by after seeing all the result, have you changed your strategies when you do them, fix them posteriorly, or do you do anything different from whatever you have talked about?
Yes. So at first, we have to consider the risk of the dysphagia by separating the upper cervical spine and the lower cervical spine. So, because in the correction in the upper cervical spine, we have to pay attention to the OC2 angle and the C1C2 angle. So the too much fraction angle in the OC2 angle or C1C2 angle is a risk factor for the dysphagia after surgery. And on the other hand, in the lower cervical spine, so we have to pay attention to the overstretch of the neck. So we have to plan the surgery by the measuring the lordotic angle and the distance. So if the patients who scheduled the lower cervical spine correction surgery, so we have to check the swallowing function before surgery, and if the patients have the swallowing dysfunction, so we have to consider the hollow vest or other thing. Thank you.
Thank you so much. And moving ahead, you know, we have exactly half an hour left. So I think it is best we can have two cases, one from Dr. Umesh and then one from Sumit. We'll keep it 15 minutes each cases. Umesh, are you ready with your case?
Oh yeah, yes. I'll just share my screen again.
Yeah, once the Umesh shares his case, I think all the faculty is most welcome to give their opinion, and let's go with it. Umesh, over to you. You have 15 minutes to finish your case. Whichever case you choose, up to you.
Okay. So my case presentation will get over soon, but it's the discussion that's going to go on. So I think we can taper the discussion according to how sure. Yeah. So again, glad to be here. So this is the case. I'll just jump right into the details. So this is a 55-year-old male, a senior physician. He's a biker, you know, likes to travel. He was diagnosed to have a cervical OPLL 3 years ago. He came to us. He had severe compression in the spine and on the cord, and even at that time, but he had only neck pain, no myelopathy signs. He led an active lifestyle. You know, there was no symptoms whatsoever, just some mild neck pain, and he was managed conservatively. 2 weeks before the presentation, he had a trivial fall, tried to lift some heavy weight, and he slipped. After that, he had neck pain, which became progressively severe. And 3 days before he came to the hospital, it was quite bad. He had radiation, atypical non-dermatomal radiation to bilateral upper limbs, associated with paresthesias in the upper limbs. More predominantly in the hands. Upper limb pain and paresthesias were more than the neck pain. There was no improvement with analgesics, no imbalance while walking, no bowel or bladder complaints. So on examination, his swelling was positive on the right. Bilateral upper limb sensations and lower limb sensations were intact. Right triceps was a little sluggish. The rest of the deep tendon reflexes were normal. There were no motor deficits. Hoffman's was negative. Rombox was negative. Plantar's was bilaterally mute. He had mild wrist extension as well as elbow extension weakness. Hand grip was weak, but he was telling that it's probably because of the severe burning paresthesias, dysesthesias, that he was not able to hold it tightly. On the left side, the hand grip was normal. So this was his MRI. This is the latest MRI. The old MRI looked almost more or less similar, except for the lower one. The upper one would look more or less similar. So I'll just go through the MRI. I'll not discuss the MRI. I think all of the seniors are there. If one of the faculty can summarize the MRI findings in the end. So this is at C2. This is at C2-3 level. There's a thick OPLL, almost a type, segmental as well as focal at a C4-5 level. And this is at C6 level. So if we observe, there is a significant compression of the spinal cord all the way from the C2 down to C6 vertebral body. And the upper level, the cervical cord was intact, whereas the lower level, probably because of the recent trauma, there was a hyper intense change, and that is what is being seen there. Now, this is the sequential sagittal sections at each of these levels. Yes. Can anybody comment on what is the MRI, and if they need your inputs about what additional points we want to see in such a case, when we get such a case, and what are the points that we should note for on the MRI?
Professor Takahata,
I want to see the.
please.
Yes.
I want to see the X-ray.
Oh yeah, I'm going to come. We have the X-rays, we have the CT scans, we have all of this. So just on MRI, just we'll go step by step. Or you want me to present the whole case?
No, that's okay. Whatever your plan. I mean, that's okay.
No, my plan is to just go through sequentially, and we will see what the MRI is showing. If the faculty, for Japanese faculty, have any comments on the MRI, and if they want to tell us what points do they look for when they find such a case. This is an OPLL mixed type, long-standing, recent history of trauma, mild, symptoms, deterioration. There is no motor deterioration. So what do you look for in the MRI before making treatment decisions? Dr. Takahata, please. I think you can take the lead and you can answer.
Yes, so according to your neurologic examination, which level is responsible for the spinal cord injury, do you think?
So according to clinical examination, he had predominantly burning sensation in the distal upper limbs. So it was non-dermatomal, as I told, and it was predominantly C7, T1.
Okay, so
C7, C7 to T1, yes.
Okay, and how was the K-line classification? So which is the most prominent?
I'll come to that. So I'll come to that in the. We are not Yeah. Okay. So I think we want to rush ahead. So this is the X-ray of the patient. Yeah. So this is the X-ray of the patient, and we measured the T1 slope was 32. The C2 to C7 lordosis was 19, and the SVA was 24 millimeters. This was the CT scan. At various levels, we can see the axial sections, very thick OPLL. There is no double dural sign at any level, double line sign at any level, and the K line. This was the K line.
Yes.
So it's near K line neutral, and only at C6 vertebral body there is a slight negative K line, but otherwise it was most of the times neutral. So anyway, so what do we do next? That is the main question. So this is a case who has come only with an acute deterioration of just sensory symptoms. So what would you recommend, Dr. Takahata? Would you go for an immediate surgery, or would you like to conserve and see how the cord edema improves over a period of time?
Yes, I think the anterior decompression at the C5-6 level is the most effective procedure for
So you want to go directly for a surgery. Is there any role for conservative? So this is an acute injury, trivial fall. There are no motor deficits. So would you directly go for a surgery, or would you just want to wait for a few days for the edema to come down?
Professor Sinha, any thoughts? What will you do? Again, you go for surgery? Professor Sumit Sinha? Are you, do you think differently, or will you go with our Japanese friends?
No, if the patient has no symptoms, or if there is no progression of symptoms, I would like the cord edema to settle down first, because fiddling around that area in the presence of severe cord edema, which I can see in the T2 weighted scans, can lead to a progression of the neurological deficits, leading to patients landing up on ventilatory support in the post-op and difficult weaning off from the ventilator. So I would rather like to wait for about 2 to 4 days for subsidence of this edema, and definitely would like to go in at the point of maximum compression, which is responsible for the patient's symptoms or neurology. So
Anterior
definitely another addition.
Anterior
Like to see
posterior.
this. No, that's what I would like to revisit the X-rays. Can you go back to the previous slide, Umesh?
Yeah, this is the CT, and these are the X-rays.
No, the X-ray.
Yeah, you want them without the, okay. So what is it that you're looking for,
Okay,
Dr.
so
Sumit? What is it that you wanted? Can you just share what you're looking for?
yeah, actually, X-ray is the most important investigation, which I believe in going for the decision in the strategy for cervical spondylotic myelopathy, because whether to go anterior or posterior. Why? Because it's number one, it's a load-bearing imaging investigation. I always tell my fellows and residents that X-ray gets you more information even than the MRI. So first of all, one has to see on X-ray, and it gives you a lot of information because it's a dynamic, it's a load-bearing dynamic X-ray. So in this X-ray, as I can see that there is rather reversal of lordosis, reversal of the lordosis at some places. There is evidence of subtle instability as well. Although this is not a dynamic X-ray, I believe this is an epilateral. I see. But I mean, I would be rather more happy with the dynamic X-ray.
So that's another question. So he has come with a history of fall, and he's after which his symptoms have worsened.
In another, he's a biker.
Sorry?
He bikes.
Yes,
right?
yes, he bikes.
If he walks only in front of the table, at the desk, so he has very different background from the normal walker. So I think we should discuss about it as well.
Yeah. So what is the point that you are trying to make? Can you tell how this social activity makes a difference?
I believe so. So this patient had high social activity, so maybe I would recommend prophylactic surgery than the other usual patients.
Okay, so Kshitij, we have 2 versus 1, 2 for surgery, 1 for conservative. What is your take, Kshitij? You are there?
So I would agree with Dr. Kitamura, because you have to see the patient as well. This is a 55-year-old biker. I mean, even if he was asymptomatic and he did not have a fall, or he has no paresthesias in his hand, if he has this, then at least the patient should be aware that he has an option. Or because now the question becomes whether he will become myelopathic in the future. He's 55 He's 55-year-old, and if he's Japanese, he's going to live another 40 years.
That is
being an Indian also, there is possibility he will live at least till 80, 85.
And we are reaching there. So
we are reaching there.
I'd like to make sure that he has a difficulty in gripping, right? So
no, difficulty in breathing.
Gripping. He's a biker.
Gripping. Yes.
Yes, and he has a severe pain on the plus stage as well.
True, correct.
So there is a neurology. There is no doubt to hear surgical intervention. Only the urgency of the surgery, which I was talking about, I think we should wait for about 3 to 4 days till the edema settles down. But there is no doubt as to the surgical intervention.
Okay, one comment.
No, it's already been 2 to 4 days. So it's already been 2 to 4 days. He has come only 2 weeks after the fall. He has come only 2 weeks after the fall.
Yeah. One last comment.
So this MRI is a.
Go ahead.
Yeah.
Yeah, Dr. Kijo, please, you have raised your hand. Do you have anything?
Can I say something?
Yeah, please.
Yeah, all right. So I will also vote for the surgery because on CT, the C56 OPLL looks like unstable. So it will progress very near future. And to combine that, he has a very weak palsy on the C6, C7 level, and he has an pain, neurological pain, and he has an unstable OPLL. So I will recommend to have the surgery for him.
I think that's a very good point. You know, he's got a fall, and probably because of the cord edema, we have to consider that the segment at C5, C6 or C6 vertebral body at that level, there is something that has worsened due to the injury. Otherwise, the cord edema shouldn't have been so significant. Now, okay, if we all agree about surgery, Dr. Shinji, can you just tell me what kind of surgery would you do in this particular case? Can you just put in, I think each of us will have a vote. We have an option of posterior surgery. We have an option of anterior surgery. We have a combined approach. So let's go with posterior first. I'll just put up all the options here. You know, we can have a discussion on all of these points. So let me start with Dr. Takahashi. So can you tell me what kind of surgery would you prefer in this particular case?
So in my opinion, this patient have the very wide OPLL, so anterior fusion surgery has a lot of the invasiveness. So I recommend the posterior fixation surgery in this patient and the wide expand from C2 to C7 and with fusion.
You want to do a fusion in this? Is there any role for laminoplasty? Dr. Takahata, you just mentioned initially that you want to do an anterior surgery. How would you like to?
So I think the anterior decompression is the most effective procedure. So, but in this case, but I think we should do the posterior decompression, laminoplasty first, and then the recovery is not sufficient enough. So maybe I should recommend anterior decompression of.
So you would like to stage it. You would like to stage the procedure. Dr. Sumit, what is your take on this? So would you like to do only posterior? Would you like to do anterior? What is your take?
Oh, well, as very rightly said by Dr. Takahata, that the compression is majority in the front, and the symptomatic compression is at C5-6, probably because he has a weakness of the grip and possibly has some proximal weakness as well on the elbow or shoulder. So what I would aim is going for both the ventral decompression at C5 and C6 and augmenting it with the posterior decompression and fusion also. This is a 360-degree combined approach.
I think, yeah, so you are going for a combined approach. Yeah, so you are going for a combined approach.
Yes.
Yeah. Dr. Kitamura, what is your take? So what would you do?
Yeah, I would go, this is very debatable, but I would go posterior decompression and fusion. And my
posterior.
Yeah, actually C5-6 has a bit big shaped and not continuous, but segmental. And we can find a minute between the ossified mass between C5 and C6. So maybe, and my another concern is that inflection, that K line will go more minor. In this kind of case, I at least fuse. At least
yes, yes. Okay.
Maybe I would go C2 down to maybe T1 at once, posterior.
Yes. That's good. Kshitij, your take. What do you want to do? You want to do all posterior? You want to do any anterior procedure at all in this case?
Can you show the X-ray again? So a laminoplasty. So a laminoplasty and
so you want to do a laminoplasty? I think we were discussing. So this is a very controversial. So you are the only person who has told laminoplasty till now. So you have a T-slope of 32. The lordosis is lost. The K line is negative or neutral.
Wait a minute. Don't put lordosis on the CT scan.
No. I put up an X-ray. Even on the X-ray also, it was almost similar. That's why I showed you the X-ray just now. This is at best a neutral. This is at best a K line neutral.
Yeah.
which is fine for a laminoplasty. Means
Umesh, we should go ahead with finish this case so that we have another case.
my argument for laminoplasty is, the guy is 55-year-old. He doesn't have myelopathy. Laminectomy with fusion has its own problems, so it's not kind of.
So on the contrary, aren't you worried that this is a young guy? There is a higher chance for progression of OPLL. Literature says around.
There is no evidence that fusion reduces the risk of progression.
No, there is evidence that we just presented. There is evidence that fusion reduces the progression. It is 6% versus, I think 60%. It is 7 times more faster after laminoplasty than after laminectomy and fusion.
A Japanese surgeon, Kawaguchi, has presented the long-term results of laminoplasty.
No, we have individual case reports. We have individual series.
I'm not talking about individual case reports. There was.
Can I step in the discussion?
Yeah, please.
This is my
then to conclude. Okay.
I would like also
5.4% recurrence rate because of my OPLL in a laminoplasty patients. 5.4% in that series.
Okay, good. So yes.
Dr. Tamai, please.
Okay, Dr. Tamai, yeah.
I would like to also perform the maybe laminoplasty only. The discussion point might be whether we need to do the fusion surgery at the C5-6 from the posterior. But as you say, the fixation surgery, fusion surgery can prevent the progression of the C5-6 OPLL. However, when we fuse the 5-6, the C4-5 OPLL might be the progress in the near future or in the future. That's why I know that laminoplasty is not the best answer in this case, but I will choose the laminoplasty first for this patient.
Thank you.
Okay. So I think Dr. Takahata, final comments about all this discussion, your final comments take, and what should be the ideal procedure?
Yeah, thank you. So I think many of the Japanese spine surgeons select the posterior decompression fusion procedure. So, but we must be careful. So when we perform posterior decompression fusion surgery, may lead to C5 piracy. So big OPL in an extensively multiple level.
Yes.
There's some papers reported high instance of C5 piracy after posterior decompression fusion. So that's why I recommend, in my opinion, I recommend posterior decompression. And if the sufficient outcomes was not achieved, so anterior decompression may be the good option for the second surgery, I think.
But
yeah, I think that is what we did. But we didn't wait to see whether he's going to improve completely. We just staged in the same day. Initially we did a posterior C2 to 7 laminectomy, C2 to D1, because the T1 slope was slightly higher for it to be left behind. And in the same time, and we turned the patient anteriorly, we did a C6 corpectomy and fusion and excised the OPLL. I think this is what was done in this particular case.
Yeah, perfect.
Any comments, and any critical comments, criticisms?
Looks very
perfect
good.
Approach.
I mean,
the posterior.
I have a critical comment to make. This is okay for a person who is quadriparetic and all. I think in my practice, I have really difficulty in selling an anterior posterior to a patient who is relatively asymptomatic. So we know.
No, he is not asymptomatic. So he had come 3 years ago with almost a similar MRI, and that time he was asymptomatic. Now he has come with a neurology. He has come with a deficit, and he wants the best chances getting back to his active lifestyle, and he wants a definitive procedure. He is not ready to.
Was intact. Isn't he neurologically?
No. He has a right grip weakness. He had a mild wrist extension as well as elbow extension weakness.
But
I think
Kshitij, for the sake of time, I think we should call it. I think it looks great. Great job, Umesh. And let's move on to the last case, we had a very heated argument here. So let's see what Dr. Sumit Sinha has to present. Over to you for the last bit of discussion. And we have 15 minutes before we close.
Yeah, thank you.
Thank you, Umesh.
It's a short case. And I have a couple of cases. I think only one case or at the most, whatever, depends upon.
Yeah. Please choose the
Sorry?
best case. Choose one case. Which
Yeah. Of course. Can you see my screen?
No, we cannot see.
Hello.
We cannot see you. Yeah, we can see the case 2.
Yeah, you can see.
Yeah, case 1. Yeah, we can see yours.
So here is a 57-year-old female. She's a housewife, and she complains of axial neck pain, which has been persistently increasing with restriction of neck movements over the last 2 years. She has a history of laminectomy. Laminectomy. Some for the complaints of in walking at that time, 3 years back, but the symptoms got temporarily resolved the previous operation, but then only to recover back about as late as 6 months back from now, when she started having again imbalance in walking, which was more just sometimes. She had trivial fall walking with support while walking, and then after that she has been hello.
Yeah, we can hear you, but your voice is breaking in between. Please go ahead. We can see the case.
Okay. You can see, okay, you can hear. So after this trivial fall, she walks with, there is a deterioration in the neurology, and she walks with support since then for the last 2 months since the fall, and she's wheelchair bound by since the last 15 days duration. So there is a fast deterioration of the neurology. There is no bladder bowel till now. And on examination, the power is 3/5, bilateral upper limbs, and in lower limbs on the left side it's 3/5, and on the left side it is 2/5, and on the right side it is 3/5. Deep tendon, all myelopathic, Hoffman clonus positive, and sensation is also reduced below C4. So that is what. So as I already mentioned, the first investigation in my choice, which I prefer to do and have a look for, is always an X-ray. But I mean, unfortunately, I don't have an X-ray in that. But this, I am showing you the CT scan. This is the CT scan of this page of this lady when she presented to me in the clinic, which showed there is absence of the lamina from C2 to C6, and complete straight spine with osteophytes at C3-4, and there is a fusion at C4-5 vertebral body. So the next investigation which I did was the MRI, of course. So it showed the compression at C3-4 and C2-3. Of course, C4 and 5 are fused before, and there is absence of lamina posteriorly. So what I keep it open now. I mean, I wanted to ask the opinion of people watching out there as to what they would have chosen, as to what the strategy is. First of all, starting from the Japanese colleagues. Hello.
Hello, Dr. Takahata speaking. So the C2-3 was spontaneously fused, congenitally fused, right?
C4-5. C4-5 was fused before.
4-5. Okay.
Yes.
So looks, yeah, the tip of the C2, it look some change, and
There is a congenital fusion at the top and there is a surgical fusion at the
There is a
top.
congenital fusion. No, there is no surgery. Anterior surgery has not been done.
So it's
There is a
a
congenital fusion 4 and 5, a sort of clinical.
I'd like to check the
There is no surgery.
C1-2 movement. C1-2. Do you have the fraction?
Unfortunately, I don't have the X-ray of this patient. They got misplaced. Unfortunately, I don't have, but there was no movement at C1 and C2. There was absolutely no movement at C1 and C2.
Yeah,
and
2 and 3 were fused, and this is a C4. I think 2 and 3 are fused, right?
Yeah, I completely support Dr. Takahata's opinion that this patient had a C2-3 fusion. So now we can see the C4 because on CT we can see the 2 pedicle between C2 and C3. Could you go to the CT scan images? So yeah,
so
this would
C2-3 is fused and C6 is fused.
Yeah, C2-3 is fused.
Yeah, and the tip of the C2 is posteriorly inclined. So, and the C1 is somewhat hyperplasia. And if the C1 to C1, C2 movement is a patient has a C1 to large movement. So I think it's possible the extension may cause a C1 posterior arch decompression to the spinal cord. So because he has a C2-3 fusion and or 5-6 fusion.
Umesh, your take on this?
But
so what is the means? I just wanted to, because you were telling about the C1 C2 dynamic what is the role for dynamic MRI in these cases? So how frequently is dynamic MRI being done in Japan and for your routine myelopathy cases and cervical? What is the role?
Yeah, I think it's a good idea to take the MRI on extension position. I agree with you.
Okay. What will you do, Umesh?
What are you expecting, doctor, in the dynamic MRI?
So the posterior C1 posterior arch compression to the spinal cord. We like to make sure if there's a dynamic spinal cord compression.
In the resting neutral MRI images, there is absolutely no evidence of any compression. And we can see, in fact, the CSF T2 in T2 weighted images, we can very well clearly see the CSF line, both anteriorly and posteriorly. The canal is very capacious at this level. More so, however, the clinical profile, the clinical neurology of the patient also does not support OC compression. So even in those cases, you would like to go for a dynamic MRI?
The dynamic MRIs, it's for me, a patient who has a laminectomy, those the dynamic MRIs can show you the invagination of the posterior epidural scar at the laminectomy defect. And that has been shown in case studies. You will have to
exactly this is what is happening.
Yeah, that's what I'm saying. You will have to take a look at those images. They are published by Dan Rue. You can take a look at it on the publication, and they have seen that even though with fusion, laminectomy and fusion patients getting extension MRIs, the posterior soft tissue.
Well, I would not. Well, well taken. The point is well taken. Well, I would in this case would not prefer to do a dynamic MRI because I am very well seeing the compression which is maximally happening anteriorly at C4-5 and C3-4, and posteriorly also what is happening is the laminectomy defect is sinking into the laminectomy site posteriorly. So the compression is both from front at these levels and on the posterior side throughout the extent of the laminectomy.
You are
so
right. I don't think it makes a difference. But there are
this case it won't.
where you wouldn't know why there is spinal cord dysfunction in a laminectomy patients, and there the dynamic MRIs make a difference. Yeah, in this case,
See, there is ample compression over here, which
I agree with you. This
so
case,
if yes, I'm talking about this case. If suppose there would have been no compression here, even then the neurology was there, then I would like to investigate it further by doing this dynamic MRI. But anyway, I didn't do this MRI in this patient because of obvious reasons, and I would like to ask the panel about what as to the strategy to deal with in this patient. What will you like to do?
Umesh, what will you do? What will be your strategy, considering whatever we have got? We have got this.
So I think in this particular case, she'll require an anterior surgery. She'll require an anterior, probably a C4 corpectomy. C2-3 is clipple field, C4 corpectomy and a fixation. And means probably I'm not so sure that dynamic MRI doesn't have a role in this particular case, because or maybe we can stage it. So we can, once the anterior decompression is adequate, probably then we can see how much of a posterior compression is still remaining and check whether,
Dr. Isolated standalone ventral surgery, or you will supplement it with a posterior at the same sitting? Or you're talking about a staged procedure?
I'm talking about a staged procedure in this case, because this is a single level corpectomy and already the lower level and upper levels are fused. So, we don't...
Any other difference of opinion from Dr. Umesh?
Can I say something?
Japanese.
This is Tamai.
Please go ahead, Tamai.
Okay, so I would like to choose the combined anterior and posterior surgery, because in this case, when we do the corpectomy, it might be difficult to achieve the higher fixation just only the plating, because the C3 and C4, C5 is fused, so it might be the getting the porosis bone. That's why I will choose the 2-level SADF and go to the posterior and the decompression and put the pedicle screw or lateral mass screw. So combined surgery might be recommended in this case.
Any reason that you are choosing a combined surgery over standalone ventral decompression?
Okay, so the decompression might be okay when the patient cannot accept the higher risk surgery, but maybe maybe the 5 years later, 10 years later, maybe this patient has a really stenosis in this level. That's why I might to choose to have the fusion surgery anyway.
Dr. Sumit, for the sake of time, please go ahead and show what you did.
So in this, this is a very unique type of a patient with unique sets of things that is happening to her, poor lady, because of the following reasons. Entire PLC is absent from C2 to C6. There is no posterior support. And on top of that, there is a laminectomy membrane which is pressing on the spinal cord. The spine is straight for all obvious reasons. The lordosis is lost because of the pre-existing clipper fall. There is fused C3-4 and C4-5. There is C2-3 and 3-4 ventral compression. So, if you remember my previous talk as to the strategy to deal whether anteriorly or posteriorly, in this case, I would prefer a 360-degree anterior plus a posterior decompression and fixation at the same time. Do the cervical corpectomy at the site of maximum compression, which is C4, and fix it with a plate anteriorly, and of course doing a lateral mass fixation from C2 to C6 posteriorly, which I did. In fact, as I told, I do IONM monitoring in all my cases routinely, both SSCP, D-Wave, and MEP monitorings, and this is what I did. C4 corpectomy, anterior and posterior fixation. The reason for doing a posterior fixation at the same sitting is I have my own sets of reasons, because there is absent PLC in the posterior side. your construct, if you apply it, standalone anterior construct is more high likely chances to fail, or pseudoarthrosis can happen anteriorly. So therefore, I wanted to augment my anterior support by doing a posterior fixation. So that's what I did. And this is the patient who's walking and pushing down and walking after the surgery. Thank you so much.
So thank you so much, Professor Sumit Sinha, for excellent case. And this brings to the end of this wonderful session. I really like to thank all of you, the Japanese friends and the Indian colleagues who sort of gave their time and contributed to the excellent discussion. At the end of it, I think we all got a little wiser. The controversies in myelopathy are endless. We sort of tried to find a common consensus. That is what we do. But at the end of the day, I think it is individualized approach, what you can do for the best for the patient, that determines the outcome, and that is where we are today. So thank you all. I think with this, we like to conclude the session, and I really appreciate all of you joining us for extensive 2 hours of discussion on cervical myelopathy. If there are any further questions or query, please mail it to us. We'll try to put up it to our esteemed faculty, and we'll get back to you for anyone who we might have missed a question from. So thank you all. Thank you for patient listening.
Thank you.
Thank you. Thank you so much.
Thank you, everyone, and bye.